Thanks. Thank you all. Everything's great so far. I appreciate you guys doing all that work.
Okay. All right, so for this case, we have a 72-year-old female. She's a patient that's snowbird, so she's from Vermont but lives in Venice for part of the year. Was initially diagnosed with AMD, but then was told when she went back to Vermont that she didn't have AMD. So a little bit of an unclear kind of diagnosis history here. She states that she feels like she's looking through a veil with her vision for the past few years. She thinks it's in both eyes, but very difficult for her to tell kind of how long the vision has been changed. And right now she's currently getting Avastin injections in the right eye. So her medical history is relatively benign besides a history of breast cancer, which she has had removed in the past, and she's currently on no medications. Her vision is pretty good in the right eye, 20/25, and slightly decreased in the left eye, 20/40. And her pressures are normal. This is the first photo here.
Okay, we have a fundus photo of the right eye. Media looks clear. The nerve looks pink and sharp. Appropriate cup to disc. The vessels are unremarkable. And then we've got this peripheral, attention's drawn to these peripheral yellowish white, medium-sized lesions, hypopigmented lesions scattered throughout the periphery. And then in the macula, looks like maybe some perifoveal kind of punctate white dots. I can see that.
Yeah, let's.
Isn't that beautiful?
Next one, yeah, here's a zoomed in picture.
Okay, so yeah, we have a zoomed in photo. Similarly, there's these kind of punctate, I don't know if it's a little blurry on my screen, but they look like very small punctate whitish lesions in the parafovea.
In the viewpoint, you can see it. So later.
Yeah.
I don't think we have, this is the other eye.
Left eye, similar sort of appearance. And there's like a inferior to the disc as well, maybe a pigmented lesion. It's it looks subretinal.
Yeah, I think we might have a zoomed in photo, yeah. Yeah, this area.
Yep. And same thing, there's those little punctate lesions in the MAC as well.
I have to say, these vessels don't look so great either. It's weird doing the cases back to back, but you look at the veins. What do you think about the veins?
Oh, I guess maybe there's some venous beading, superior, kind of the superior arcade. It looks like maybe there's some venous beading up there, maybe some avinicate.
At least the caliber. So here it's like fat, and then narrow, and then fat.
Irregular.
Yeah, irregular, and then narrow.
Oh,
here.
irregular caliber, not venous beading.
Irregular caliber, which is not normal.
Yeah, really good.
It's interesting, when we talk about the vessels on the photos, you're not actually seeing the vessel, you're seeing the blood column. Just so you know, the vessels are largely transparent.
Okay, if we go forward, this is for OCT.
Okay, so we have an OCT of the right eye. There are maybe some cells in the vitreous that are more visible here than in the fundus photos. And we've got some cystic intraretinal fluid. The RPE looks a little elevated, just a little temporal, maybe kind of separated from Brooks there. Maybe some ellipsoid zone discontinuity that's just underneath that cystic fluid.
And some of
And
that could be shadowing, so I see what you're talking about, it's like it's a little irregular, just temporal phobia. But some of that could be just lack of signal, you know, because you got all these lesions in front of it. So like right there, that may be discontinuity, but it might just be these funny looking, I mean, the vessels here are a little dilated, the capillaries, you got the cysts. So it could just be.
And I think we have we have another photo.
Yeah, the other one's
Kind of
horizontal, this is
shows
vertical.
this a little bit better.
okay, yeah, similarly, we can see some elevation of the RPE from Brooks. And yeah, it looks a little irregular. And then a pocket of cystic fluid as well, distortion of the foveal contour. And we still see those vitreous, that debris or cells in the vitreous.
Mhm. Yeah, really good. And this is the other eye.
Left eye, not as significant, but there still some vitreous debris or cells. And in this eye, no cystic fluid, foveal contour looks more regular, and I don't see any RPE disruption or outer retinal disruption.
Yeah, I agree. I thought this eye looked better than the other eye.
Mm.
This is kind of what I was seeing on this area.
Mm-hmm. Yeah, again, just some elevation of the RPE.
You guys just call that like irregularity in elevation? Wasn't
Yeah, it's
this eye
interesting,
which I
so
was like,
you
it
can,
wasn't
we
like-
talk about the double layer sign with macular degeneration.
Yeah.
And it would actually almost qualify if this were a macular degeneration as a double layer sign. But yeah, so I would just say RP, pick RP thickening and just
Well,
like you said.
is that Brookstead behind it, or is that?
Yeah, this one you can see Brooks, so kind of,
You think
Brooks
that-
split.
That is Brook.
Yeah, so well, it's probably not all of Brooks. So that's probably the basement membrane of the choriocapillaris, and then you probably have the basement membrane of the RP.
But the RPE is above, there's a little lucid area, then you'd say the RP is elevated.
Yeah, I think so.
Okay.
And I think we have a bunch of photos here, so I can kind of go through them and back and forth for you.
So go to that first one though, what's that?
Okay, so we have a autofluorescent photo of the right and left eye. So we'll start with the right eye. So we've got these hypo-fluorescent lesions kind of scattered throughout and in the MAC as well. And then we have these hyper-fluorescent lesions in the supratemporal MAC and inferior retina. And superior retina as well. And then in the left eye, kind of a similar picture. We've got those hypofluorescent lesions that are kind of clustered in the MAC in a few large spots, like 1 disc diameter spots. And then we have smaller areas of hypofluorescence more concentrated in the inferior macula, and not as many of those hyperfluorescent areas or punctate spots in the left eye.
And on autofluorescence, do you remember your 2 causes of hypoautofluorescence? There's only 2.
Hypoautofluorescence so you can have blockage,
Good.
or you can have RPE defect, I suppose.
Yeah, reduced signal, so it's either blockage or reduced signal, and there was nothing blocking there, right? So this is just kind of dead or very, very sick RP. The thing is, sick RP tends to hyperautofluoresce. So this is a little bit of a weird case. This is a funny looking autofluorescence. This lady, I think, has had this. I saw her again on Tuesday, and she must have had this a long time. So she's got some very sick and dead RPE back there. That's just kind of given up on autofluorescing.
And then here I can kind of go through these. We can go back and forth.
Good, so what do you see there? Which type of, is this what kind of image is that? Go back to the first one.
The FA of the right eye. So in the first photo, we have the arterial phase. You can see there are some patchy areas of hypo-fluorescence and hyper-fluorescence. I think you can kind of start to see some, it looks like, well, I guess I'd have to wait and see, but staining versus leakage along the superior and inferior arcade, because it looks like it's enlarging, and kind of those round areas. There's a small area that's along the inferior arcade, and then a larger area along the superior arcade where it looks like it's maybe even staining.
It's a little early. Keep going. The next one would be better for that. There you go.
Oh, now we have in the left photo, we have the AV phase. There's some parapapillary hyperfluorescence as well as patchy areas of hyperfluorescence that are kind of along the arcades and the peripheral retina, and then a few spots in the macula as well, along with some small areas of hypofluorescence.
Okay, go ahead. And that's a lay to the right eye.
And then, okay, so we've got some leakage around the nerve. It's kind of highlighting, and then so this is a late phase. We've got still the patchy areas of hyperfluorescence, and looks like a hypofluorescent spot right in the center of the mac.
Right, which is probably the macular pigment, and then just temporal with that, you can see those cysts filling. So you can see that little cutout, almost like a reverse eclipse, where the cyst is filling centrally. Right here, yeah, right there. So that's one of those cysts filling that you saw in the OCT.
I think we have the other eye.
Okay, left eye, so kind of similar. We've got those patchy areas of hyperfluorescence, and the peripapillary leakage as well. It's more apparent in the later phase, and I think those areas surrounding and the outside the mac corresponding with the whitish hypopigmented areas that we saw in the fundus photos.
And then one thing you'll notice on the ultra wide FA, the one on the right, is the spots that you saw in the color picture don't really show up that well in the FA. So you don't really see those. You see some spots nasally, but they're not really the same. They're not the same shape. They're just sort of, everything's just kind of bright. They're not discrete spots like you saw in the color photo.
Yeah, I think we'll see that in one of these upcoming photos.
Yeah. So those are staining. So that's an example of staining. You have a solid space that's filling with fluorescein, and it's not, the edges aren't changing that much. So those two lesions are stained.
Are there hypopigmented lesions in those areas on the colors?
Yes, yeah, I think so. Yeah, that's the OCT shows them. That's those RP thickened areas. The areas where the RP was just kind of thick. And
Can we go back to the earlier fluorescein? Way back, keep going. So they really fill pretty quickly.
Yeah, they stain pretty quickly. Yeah.
Okay. So
Yeah, they don't look like membranes though. They don't look like
they don't look like pure scar either.
Yeah, they're like hydrophilic.
I mean, because they fill in from the side, so they're gonna be hypofluorescent in the beginning. These are pick up the dye immediately.
They're kind of funny looking lesions. Because the fact that they hypofluoresce on autofluorescence and hyperfluorescence, they're just these hydrophilic drusen lead, like RP, it's pretty sick RP. It's interesting.
What about those dots, those white dots, the hyper-fluorescent dots in the supratemporal right macula?
In the right eye,
Yeah,
keep going. Go forward a little bit.
they don't do that much, do they?
No, the ones you saw in the color picture, or the ones?
No, on the hyper autofluorescent dots, the pinpoint ones, yeah.
Oh, those guys. Yeah, those are funny looking. I think those are more acute. I think everything here is kind of chronic and old. I think those are maybe some little acute lesions. Yeah, those are, yeah, what do those show? It's true, I'm not sure what they are. Those are probably little punctate subretinal deposits.
Okay. We don't have an OCT through
I don't think so.
them. Okay.
The line might catch them. Well, if you go back to the OCT in the right eye, this is the left, go back, back, back. That one, those, yeah, they look like, those look like, almost like pseudodrusen. So it's these guys over here. That would be the little spots.
Okay,
Oh, yeah.
all right. Thank you.
Okay, so we have ICGA of the right eye in the earlier and then a later phase. So I think what this is highlighting, those punctate or those larger white lesions that we saw in the fundus photo, you can see them here as hypo-fluorescent spots. If you could compare, I think that's probably what it's corresponding to.
Yes, yeah. And I have one lady, I just saw her last week too. I have one lady, I diagnosed Birdshot out where her fundus was truly normal looking. And everything was normal. And then I got the late ICG and there was all this crap in the periphery. And the Birdshot just lit up. So the wide field ICG, I think is great for Birdshot. And it looks kind of distinctive.
And this is showing similar.
And it's the later one. So the early one, you don't necessarily see it, but the later, like 5-10 minutes, you start to see those dark spots show up.
Are there more spots here than you can see clinically?
I think so.
Yeah, me too. Which is characteristic of
Yeah, most
white
of these,
dots.
yeah, most of these things. All right, nice.
Okay. So just kind of as a case summary here, we have a 72-year-old female. She's having bilateral blurry vision and receiving Avastin injections. The fundus photo, you see this like multiple kind of creamy yellow-white lesions of the retina or choroid that are scattered throughout the posterior pole. You're seeing cystoid macular edema on OCT and kind of some RPE irregularity, maybe some outer retinal atrophy remodeling. And then the FA, you're seeing these scattered hyper-fluorescent lesions in the posterior pole with maybe some staining versus leakage, and then leakage of the optic nerve. And then with the ICG, you're seeing these hypo-fluorescent lesions that correspond to those white lesions that you see in the fundus photos. So what would be your differential?
So I think at the top of the differential is going to be those white dot syndromes, Birdshot being one that has medium-sized lesions. Vitritis, although she's a little bit old to have an initial diagnosis of that, I think it's usually middle age. And then like AMPI, multifocal choroiditis, because she did have some vitritis as well. And then anytime you think about white dot syndromes, you have to consider syphilis as well. Other causes of uveitis, like infectious etiologies, toxo, TB, other autoimmune conditions like sarcoidosis. She also has history of breast cancer. It doesn't quite look like that, but maybe metastatic breast cancer. Yeah.
Yeah, that's really good. You got kind of everything I had on there too. Like you're thinking of kind of all the white dot syndromes, but then also like those categories we talked about before, like autoimmune versus infectious versus neoplastic. So she does have that history of breast cancer. There's something to consider. And then also thinking about like any infectious etiologies.
Pseudo lymphoma can look like this. CNS lymphoma can look a lot like this. It's weird.
Okay, and then this is just some extra information. So she had a lot of testing in Vermont and she was told she had a positive HLA A-29. So would that make you think of anything specific now at the top of your differential?
Birdshot.
Nice. Yep, so her diagnosis was birdshot. So just some teaching points just to kind of, I wanted to go over like some of the white dot syndromes, because definitely didn't know like a lot about them, and it's kind of like, oh, they all have white dots, so a little bit confusing. But I hope maybe this is helpful. I tried to make this diagram, actually based on like the Eyes for Ears podcast, this episode, and it kind of just pointed out some differences to help you separate them, to maybe help you on tests, but essentially I have them here kind of starting from top to bottom is what they organize them as, kind of like best prognosis going towards worst prognosis, and you guys can chime in, if you disagree, but essentially the first division here is they're all bilateral except for muse. So if you have a white dot syndrome that your symptoms is for that's unilateral, you're thinking muse, and then everything else should be bilateral. So then as you go down kind of the other white dot syndromes, you're starting with, the acute posterior multifocal placoid pigment epitheliopathy, which is these larger plaque-like lesions. And important, the picture is kind of there on the side there. You can see, I know they're kind of small, but important to note there is that that can have a significant systemic association with cerebral vasculitis. And the next one going down is birdshot uveitis, and that is kind of classic for this presentation. It's almost seen exclusively associated with the HLA A-29, and you can commonly get cystoid macular.
Carol.
When he comes to flinch.
Go ahead,
Thank you.
Courtney, I think.
It's okay. And then I was reading too, I don't really know, tell me what you guys think, but now sometimes like punctate inner chorioretinopathy and multifocal is kind of considered a spectrum, is what I was reading. Sometimes now it can be classified as
Yes,
like.
yeah, there's,
PIC.
I can tell you, Dr. Gass took to his, I think, end of days, felt like PIC was just multifocal choroiditis.
Yeah.
But then Lee Jampel, I think, who also describes that, feels like PIC is separate. I think PIC is separate.
Okay.
I've seen PIC is sort of young myopic women.
Mhm.
They're small, they're 50 micron spots. They tend to cluster in the macula.
Mhm.
I think it really is someday somebody will figure out the virus or whatever it is that causes all these things, but PIC really does look a lot different from the multifocals that I've seen. But the multifocal is tricky, because sometimes there's like I have a woman, I might bring her to eventually, a relatively young realtor, I think. No, she's an insurance agent. She's got one spot right in the middle of her fovea. And I think it's just like a multifocal choroiditis with a single spot, which is right, because she responds to steroids. So sometimes the multifocals can just be a single spot. But yeah, I think I would split them, but and also the neovascularization is super common in PIC. In multifocal, not necessarily as much.
Okay. Yeah, so I kind of had them split, and they were saying that PIC is normally not associated with vitritis, where you're gonna see a little bit of vitritis in all the others. So that's kind of something else that can help you differentiate. And then for the last two, multifocal, you have a high rate of CMV formation, which is, I think, why they're saying kind of the prognosis factor for that one. And then serpiginous, you're getting these snake-like lesions that come mostly from the optic nerve, and they leave these geographic scars, and there's associated vasculitis with this. It's commonly has a poor prognosis and can commonly reoccur.
That's beautiful.
Yeah, that's beautiful. And then just a few points about birdshot specifically, kind of as you just mentioned, it's going to be bilateral, and kind of our understanding is that it's some sort of T-cell autoimmune inflammation of the choroid, and patients can present with blurred visions, maybe some floaters, and as the disease progresses, you can get trouble with night vision and contrast sensitivity and sometimes color vision. On your exam, you're gonna see like a mild vitreous inflammation and those creamy yellow-white lesions scattered around the posterior pole. And then this is prone to reoccurrence. So you can have reoccurrent episodes of inflammation, even with treatment. And almost all patients, like over 90% is associated and test positive for this HLA A-29. So it's pretty specific for testing at least. And then for imaging, this case was pretty classic. So you're getting FA showing some leakage from the vessels and the optic nerve head, and you can commonly get cystoid macular edema and some outer retinal atrophy with this. And then like Dr. Cohn was saying, that the choroidal, the ICG is where you can see those choroidal lesions that correspond with the creamy colored lesions you're seeing on the fundus. And so that's just the representative image.
Thanks for that. That was great. So the thing I was concerned about was, does she also have macular degeneration? And it took me a little digging, but the Birdshot, she's a weird case in that she didn't present until now. And she probably, so she's chronically inflamed, and chronic inflammation can cause the pigment epithelial changes. So she really just had Birdshot. Those spots are not drusen, and their RP changes from chronic inflammation. And that's why they look, I think, a little different on the imaging. So she doesn't, so I think it's I wish I could tag my cases. I'm trying to keep track of them more. I should add this to the list, but I see so many people who are just, because there's so many medical retina people working out there just, without fluorescein, without really a deep knowledge of retina even, or people who aren't really medical retina, they're just doctors doing medical retina. And just when there's swelling in the retina and there's drusen, they just give shots. So it's just like shot. So she had somebody down here. I mean, I don't know how someone could look at that fundus and not see Birdshot.
Yeah.
Who could see macular degeneration, but unless they just weren't looking or weren't trained. So the idea of just giving shots to everybody was wrong. And what I've seen on a lot of patients is some uveitis. So there's a number of patients. I think I wouldn't be surprised if there's 1 or 2% of patients on frequent monthly shots because they're resistant who actually have low-grade uveitis untreated while they're getting the shots. Because in a fluorescein shows it because the nerve lights up, but nobody gets fluoresceins anymore. That was good. That was very nice. Thank you.
I have a quick question.
Absolutely.
Yeah, so this is Khaled. I was reading something recently, and I was surprised that this wasn't really a focus of my education for the past 4 years. I never really heard of it until recently, but apparently, and again, whether this is causation or just a random correlation is debatable. Apparently, there's a 1 in 200 to 1 in 500 chance of stroke after intravitreal anti-VEGF injection. And I don't think I ever counseled a patient on that. And I was very surprised to find that out. And upon further reading, it looks like there's like a study out of Taiwan that they found severely increased risk further than that if they had stroke within the past year. Do you ever counsel patients on this, or do you change management?
I don't. And the stroke thing, it's interesting you found it, but the stroke thing's been going on since the beginning of the anti-VEGFs, and it's got a long history. And what happened was, I believe, Marina, the Marina and Anchor, the first studies with Lucentis did show a slightly increased, because that was the only one that was truly placebo controlled without an anti-VEGF in the control group. And that one did show a slight increased risk of stroke. So when they first came out in 2005, we were all like a little nervous about stroke. And then what happened after that was there were a number of other ones done, and then people have looked at the Medicare database and people looked at large data sets. And the difficulty is this group of patients is prone to strokes. So you get a bunch of 80 and 90 and 100-year-old patients, and you start doing anything to them, and a large proportions are going to get strokes. Some of the studies actually showed a lower risk of stroke in the anti-VEGF group. And then a number of the studies initially, and this isn't true anymore, but I think probably the ILEA studies, whatever they were, I think you guys know the names better than me now, but they were around 2008. They actually, an exclusion criteria was a history of stroke. So you couldn't get into the studies if you had a stroke because they were so worried about subsequent strokes. Now, if you look at the Vabysmo studies and all the current, like we're doing probably, I don't know, we do 20 studies. We probably have 5 or 10, 5 wet AMD studies. I don't think stroke's an exclusion in any of them. So I think the consensus now is that even though you'll find some studies out there pegging stroke on anti-VEGF, it's largely not it's probably an association and not a causation. And I've gotten to the point where I don't discuss it, and I've gotten to the point where if I have someone who has a recent stroke, I actually still treat them. For a while, I wasn't treating them, and now I do, because I don't think it's a real risk. So-
So, Avastin is used in cancer treatment systemically, and that's really a horse of a different color. Were those patients getting stroke?
Yes, that's so systemic, so that's the difference. The other thing you'll find is if you look at the cancer literature, the anti-VEGFs given systemically for cancer, I think do have a significant risk of stroke. So that's the thing, and the systemic exposure. So it's like you always think, what would I do for myself? And I think if I had a recent stroke, I might hold the anti-VEGF. But the thing is, then you can lose vision. For a while, we were switching to Lucentis because the idea was Lucentis didn't persist in the circulation. Your body has this weird way of preserving antibodies and then destroying everything else in your circulation. So the Avastin, and I think the Eylea, the ones that have a tail, your body tries not to destroy anything with a tail. So the idea was the fragment ones, it's this whole thing, which I used to know, where it actually phagocytizes them, but then it spits them out whole. Whereas if it doesn't have a tail, it phagocytizes and destroys them. So the thought was that the Lucentis and maybe even Biovi, which isn't on the market, the ones that are fragments might be a little safer. But then the weird thing was the studies would show otherwise. So if you looked at the 1,000 people in a study, you'd say, no, there were actually more strokes in those patients. So it's a thing of science versus studies versus all the literature. So yeah, I think it's okay. It's a long answer to I actually don't modify things much or consent them. But I do